Welcome to AETCM channel.
Yes.
Yeah. 58-year-old male patient, non-case of diabetes on OHA and chronic liver disease, came with complaints of 1 episode of hematemesis and 3 episodes of melena. On initial 10-second assessment, patient is conscious and obeying commands. On primary survey, airway was patent, talking in full sentences, no pooling of secretions, gurgling or stridor. On coming to breathing, maintaining XPO2 99% in room air with respiratory rate of 18 per minute. Bilateral air entry equal and there is no added sounds. Coming to circulation, BP is 100/80 mm of Hg, heart rate is 86 per minute, peripheral pulsation are equally felt bilaterally, CRT less than 2 seconds. At that point,
what was the BP you said? BP you said?
100/80.
Okay.
Heart rate is 86 per minute. And at that point, we insert 2 large bore IV cannula are inserted. And GCS is 15/15, pupil is 2.5 mm, equal, bilaterally reactive. GRBS was 312 milligram per dl. On exposure, temperature is afebrile. Adjuncts to primary survey, ABG was taken, which shows pH of 7.416, PCO2 29.8, SPO2 99.8, and PO2 169, and HCO3 is 18.8. Lactate is 3.5. Potassium is 3.9 and sodium is 135. We also done CBC CRP point of care, which shows WBC 2.9, CRP of 91.9, HB is 12.2. The last recorded HB is 13.6 and hematocrit in the present CBCRP is 38.8. Platelet is 54,000 and INR was 2.1. We have sent all the routine investigations, LFT, APTT, PT with INR, RFT, sodium, potassium, calcium, magnesium and blood grouping and cross matching. We arranged PRBC and kept the patient in NPO. The sample history, 58-year-old male patient, non-case of chronic liver disease, diabetes mellitus, presented to ER with 1 episode of hematemesis and 3 episodes of melena within 2 to 3 hours. Dark red colored vomitus with clots. Melena was dark tarry colored. No history of fever or abdominal pain, constipation or decreased urine output. Patient also complains of altered sleep rhythm for the past 2 weeks with increased daytime sleepiness. Patient was not allergic to medications. Last meal was around 2 hours back. General examination was done. In general examination, there was pallor, abdominal distension and bilateral mild pedal edema and loss of axillary and pubic hair. But there is no parotid enlargement, gynecomastia or testicular atrophy and spider navy. And on systemic examination, GIT, soft, distended, non-tender, bowel sounds present. On chest, air entry bilaterally equal. CVS, S1, S2 heard and CNS, there is no flapping tremor. And
okay.
Management.
So, tell me a prescription that you are going to write for this patient.
Whenever a patient came with upper GI bleed, we start on high dose proton pump inhibitors.
Prescription, here I wanted an emergency medicine perspective prescription. So, emergency medicine perspective prescription, what we have to think, we will plan for ABCD, right? So, airway, you said it is patent. Breathing, circulation, everything is okay right now. So, what is the primary thing that you wanted to treat? He's having vomiting right now. So, antiemetic, what you wanted to give. Second one, whatever you suggested. Then tell me what are the orders that you wanted to get. You said a lot of investigation. Suppose what are the resource limited settings, which are the mandatory investigations that you wanted in this patient. And the next question that I wanted to know, when will you transfuse a PRBC? So these are the questions that we'll be answering. And finally, who all needs an urgent endoscopy? So this is the only thing that I wanted to discuss here. So tell me the prescription that you wanted to write.
We start on antiemetic and increased gastric motility drug like Perinome.
Okay, Perinome, agreed. Okay, then.
And proton pump inhibitor like Pantoprazole.
Okay, so how much Pantoprazole you wanted to give?
ATMG IV stat. There is already a CLD patient, so there is more chances for esophageal varices.
Okay.
So infusion is less needed.
Infusion is not needed, not less needed, this not needed. 80 mg stat is what is recommended, or 40 mg BD is that what you need for this patient. Even if you have a patient with stress ulcer, 80 mg BD is a very good dose. So 80 mg stat you have given. Infusion not needed. Specifically, why I am saying not needed? It's a varicose bleed from the background history what you are selling. Okay, agreed. Then next thing.
In the previous OGDscopy, they shows there is esophageal varices.
Okay.
So better to start splanchnic vasoconstrictors like octreotide or
Okay.
terlipressin.
Octreotide, what is the dose of octreotide that you want to
100
start?
mcg stat followed by 50 mcg per hour infusion
Okay, how long you need to continue?
till endoscopy done.
Till endoscopy, you are
and
doing a
banding.
mechanical ligation. We are doing till that time. You have to continue. Then next.
Then we have to look for any HB drop for the patient.
Next, what medication you wanted to give for this patient?
Blood is a good culture medium, so we have to start some antibiotic.
100% we have to start on antibiotic. There is no doubt, because you have to, because there are two reasons. It's an CLD patient with upper GI bleed. Already from the history you are given, he has already gone into hepatic encephalopathy. Grade 1 hepatic encephalopathy. Flaps is not there. So definitely you want to start a broad spectrum antibiotic with a pretty good gram negative coverage. So what will be the choice that you wanted to start? Piperacillin tazobactam, yes, I will agree. When you have a recurrent SBP with upper GI bleed, maybe piperacillin tazobactam. Otherwise, a ceftriaxone will be more than enough. Okay, then. What are the other agents that you wanted to give in this patient? Not immediately. You want to put a Ryle's tube or not?
Ryle's tube. In esophageal varices, we usually don't put Ryle's tube.
Ulcer?
Usually it will dislodge the clot.
Now the present concept of putting an Ryle's tube, previously it was helping to guide the diagnosis. When we have a doubt in our mind, we can put. But right now it does not need it. Previously they used to say you can just aspirate and clear the stomach so that it will be better for endoscopy and all. We have prokinetic agents where you can give like erythromycin. This is again a prokinetic agent, 250 mg you can give, so that it will help to clear prior to endoscopy. That is very important. So preferably no Ryle's tube insertion. So the next thing, what you wanted to give for this patient will be what? You have to treat what else? What is the main complication that this patient is having?
Hepatic
encephalopathy. So what is the treatment that you want to give for hepatic encephalopathy?
Stool laxatives like
syrup lactulose. If the patient is kept NPO, even you can give syrup lactulose. It should not be withheld. So that is very important. You have to continue with lactulose. If otherwise he is unable to take orally, you can give lactulose retention anymore. So next, what all things that you will monitor in this patient? 2 or 3 things what you will definitely need to monitor. One, you said recently, you said hemoglobin. So when you will ask for a hemoglobin transfusion?
When the
in upper GI bleed.
When there is less than 7 gram per day.
It is evidence what is showing is less than 7 gram. Unless and until you have a cardiac failure or anything, you can go and keep it above 10. But in routine, it is 7 gram per deciliter. What is the target? Less than that, you need to transfuse your hemoglobin. Any role for tranexamic acid? There are a lot of literature reviews that they are saying that tranexamic acid can be given, but there is no mortality, no morbidity benefit. So tranexamic acid is generally not indicated in an upper GI bleed. So we have arranged for blood. Only thing that is required, if it's clearly a variceal bleed, we are not going to discuss an ulcer bleed. It's a variceal bleed, you have started off this thing. Then what else you wanted to give to this patient additionally? It's a chronic alcoholic patient. So what else you wanted to think of?
Injection thiamine.
Thiamine has to be given, and you're going to keep him nil per orally. But again, the sugars are on the higher side for this patient right now. So we have to be little bit vigilant. We don't want to aggressively go ahead and give dextrose and all, but we have to definitely treat this patient with thiamine. There is no contraindication. We have to give 500 mg of IV or 200 mg, depending upon the risk of going for a vernicase. Depending upon that, you can decide. Then what else you wanted to look in for? I asked you a question, endoscopy. When you want an endoscopy?
If there is active hematemesis.
Okay. Ideally, 12 to 24 hours. 12 to 24 hours is the idea. 24 hours was there, but now 12 hours is better. When there is an ongoing hemorrhage, when the hemoglobin drop is there, when all your mechanism of your drugs have given failed, you can call for an immediate endoscopy. You can use the scoring system. There are a lot of scoring system. One is Blatchford, then GB score is there, then AIM 65. AIM 65 score is there. More than 2, there is a higher risk. So AIM 65 basically, what are the things that will comes under AIM 65? Age more than 65, then altered Mendel status, then blood pressure, hypotension, INR, and age. Age already we have said. Anemia.
It is anemia.
So these are the things that you have to think in for. So if the score is above 2, then there is a higher risk. So whatever be the scoring system that they are saying, you have to understand that whether you need an early endoscopy. It's always better to go ahead and do an early endoscopy. Now the challenges as an emergency physician, what we feel, securing the airway is one of the biggest challenge, because the problem is that already if he is having an active hematemesis, you wanted to intubate him. So preferably avoid bag mask ventilation as much as possible. You can put him on a high flow nasal cannula. Why I am saying you this? Because once you're distending the stomach again, the moment you're planning to intubate, there is a high chance of aspiration, especially we are using succinyl cooling, because that will again increase the intragastric pressure and chance of aspiration is very high. So you have to be very vigilant, and preferably if you are able to maybe 30 to 45 degree, keep him head high and you are able to intubate, that will be better. But it will difficulty challenges are there. When you have video laryngoscope and all, you can do. And another important thing, you have to do an active suctioning. So always make sure that suction assisted intubation is one of the important technique. There is something called a Salad technique. Salad technique is there, or else you can connect. Ideally, what they are saying, you can have the meconium aspirator. You can connect the meconium aspirator to the ET tube end, and you can go ahead and intubate the patient, because there can be a lot of pool of blood seen, so it might be difficult for us to intubate. And which will be the preferable induction agent if you wanted to use an induction agent in an upper GI bleed? What will be an ideal induction agent? Ketamine. If there is hypotension, ketamine will be 1 to 1.5 mg per kg, will be an ideal induction agent for this case. And rocuronium, as I said, succinyl choline can increase the intragastric pressure. So rocuronium will be an ideal agent to go ahead and intubate. Any role when you want to activate massive transfusion protocol, MTP, where you will activate?
Loss of blood volume more than
There is significant hematemesis is there. You are seeing that more than 2 liters of blood has come. He is continuously actively bleeding. So all those things you have to activate the massive transfusion protocol. And another important thing you have to give for this patient will be an FFP and vitamin K. Why? Because already INR is deranged. Platelet again, it is 50,000. Active hemorrhage is there. You need to transfuse platelet also. I'm not saying because of MTP, because of this patient's condition. The next important thing, what is refractory hematemesis. The patient you have given already all this medication, still the hemorrhage, you have done an endoscopy also, they are unable to find anything, but still the patient is having active hemorrhage. So what we will do? We have done that for a patient few days back in our ED. Sengs taken, black humor tube. Sengs taken, black humor tube, Minnesota tube, lot of tubes are available. So it's basically you have got two balloons, so where you will have gastric as well as esophageal pressure will be given, and that is the only final resort. When you don't have anything, that is only the final resort for you to prevent that. So that is the final answer. And the complication is it can cause pressure necrosis. It is a little bit challenging, but it might be the as a last resort we can apply a Minnesota tube, or what is available in our hospital is something called a Sengs taken Blakemore tube. It's basically a balloon tamponade that we are going to give for an upper GI bleed. So the important take-home message, what you wanted to remember is here. What, depending, you can have majority two types of upper GI bleed. You will have common things what we'll see in emergency room. Three things that you need to remember. One is your ulcer bleed, variceal bleed, and third one is your malarious. This will be the three most common type of hematemesis that we are going to get. And you can have very rarely malformation and all other related bleed. But these are the three most common things that you need to keep in your mind. Our treatment aspects, basically pantoprazole, plus or minus in upper GI bleed, infusion definitely not required in a variceal bleed, but other one ulcer bleed, there is justification, and you have to risk stratify the patient. What are the risk factor? You have to go and H. pylori testing and for the non-variceal bleeder. So variceal bleeders, remember, they will have already having underlying complication. Infection will be one of the major complications, so we need to tackle that, and it can precipitate hepatic encephalopathy. Okay, fine. Thank you.